Well, thank you all for being here on a Saturday. And it's actually really exciting to be in person. This is my first patient meeting I've done in person. I've done a lot of virtual talks the last couple of years, but it's not the same. So I'm excited to be here. So today, I will take the next 20 minutes just to talk about relapsed and refractory disease. And I think Dr. Hansley, one of my fantastic colleagues, is right after me. And then Rebecca Liu, one of our awesome research nurses, she's a supervisor for our research trials at MD Anderson, will talk much more details about what clinical trials are. So my goal is to set them up for their talks. Some of the things we talk about will be, they'll overlap, but hopefully seeing it in different ways will kind of make it click a little bit better, because some of these topics are definitely a little bit more complicated. So with that, talk overview, we'll talk about understanding the implications. What does it mean to be relapsed? What does it mean to be refractory? Just even the definition of what that is. The role of clinical trials. So I'll explain, about where clinical trials are important. But again, Becca Liu in the third session will go into much more detail about this. I guess this is working now, sorry. And then I'll sort of end with, more of why it's so important to have a myeloma specialist in your care, because of the fact that we have so many different options now. How do you pick what's the right thing for each patient? So when somebody sees only myeloma, we know this sort of like the back of our hands. We still think about it. It's not an automatic algorithm or a choice, but we know what to look for to say, what is the best treatment for my patient right here? All right, so next slide, please. Perfect. So what is relapsed disease? So relapse is usually what we consider when someone is, they had their initial treatment, they're in first line, they're on maintenance, and maybe they stopped. And then we start seeing that the myeloma is coming back. And I'll talk about clinical relapse versus biochemical relapse. In all honesty, we try to make sure we find it in biochemical relapse, because we want to make sure we treat before you have organ damage or worsening organ damage. But it depends on each patient and sort of how aggressive your myeloma is. So for the next few, sorry, I had some animations on here. But basically, if you talk about clinical relapse, that's what the next few, let me see if this works. Perfect. Okay. So basically it's looking at your organs. So we talked about the Crab criteria earlier today. So if your bones, if you have new bone lesions or plasmacytomas, then we consider that a clinical organ relapse. If your hemoglobin drops by 2, or if your calcium is increased by more than an 11.5. And again, any of these things that are happening, we have to make sure they're related to myeloma. So sometimes people can have iron deficiency anemia or B12 deficiency anemia. So it's really important that we decide that this is really related to your myeloma coming back up, and that's why we need to change treatment. But a lot of times we find out that there's something else going on, we fix that, and we don't consider that a relapse. And then there's calcium. Next slide. Perfect. So then what's a biochemical progression? So this is based on those labs, all those crazy proteins we're checking on in your blood and your urine. So different patients have different proteins that are there when the myeloma is present. So M protein is one of the main ones we look at. So if someone's M protein went down to 0 and we slowly see it go up to 0.5, we consider that a biochemical progression. That doesn't mean you need to start treatment right away. I'm going to go into that in a little bit. But that's one marker. For patients who have protein in their urine, if the protein goes away or it's decreased, we see it come back up over time. Then once it gets to 200 milligrams of what we call Bence-Jones protein, that's really what we're looking for. And again, you don't have to memorize all these. These are all IMWG criteria, but a lot of my patients just like to know what I'm looking for. So I'm kind of just describing it. And then patients who don't have M proteins or proteins in their urine, sometimes there's patients who only have light chain disease, so kappa or lambda light chains. That's what we're following then. And if it goes up above, there's different definitions of it, but we're following. And if it gets to that, greater than 100 or a difference of 100, those are our patients we're watching much more closely and potentially starting treatment early if we need to. Perfect. So that's relapse disease. So again, usually we call it a relapse when the disease is coming back and you're not necessarily on treatment. Refractory, the main definition with the next button is if you're on treatment and your myeloma is starting to progress. So all those things we just talked about with the clinical or the biochemical progression, if you're on treatment, so if you're on lenalidomide maintenance or within 60 days, that's the other definition of stopping, but it's really early after stopping, then we call your disease refractory, that it's resistant to that lenalidomide. Or if someone is on, let's say, Dara-Pomdex or something that we're treating as in second line or third line, and we now start seeing these numbers go up, or we see a definite progression, we call it refractory, that treatment. So what does triple refractory mean? So a lot of the clinical studies we look at now talk about patients who are triple refractory or even penta-refractory. And then triple refractory is when patients are resistant. So they were on a proteasome inhibitor like bortezomib or Velcade. They were on, let's say, an IMiD like Revlimid or lenalidomide, and they were on a CD38 inhibitor, so either daratumumab or isatuximab, and you're relapsing while on those drugs or within 60 days. So that means you're triple refractory. The next definition is what is penta-refractory, and then I'll explain why this is important. Penta-refractory is the same type of situation, but now patients have been refractory to both lenalidomide and pomalidomide, which are both IMiDs, and you've been refractory to both Velcade or bortezomib and carfilzomib, which are both PIs. So that's all 5 of our sort of main drugs that we use that are standard of care that we've had for a while. But if you're refractory to all those, that's considered penta-refractory. So why is this important? When patients are going through therapy, we need to know each myeloma patient's different. So when people ask me, what is my risk? What am I thinking? It's sort of like what we call acute leukemia and chronic leukemia. Some people have really aggressive disease that we call high risk disease, that when it comes back, it's coming back with lots of force, and we need to really knock it down when we use multiple drugs quickly to knock it down. And then other people have myeloma that's really slow growing. And so when we choose therapies, we need to know that in the background so we can give you that best response to get this myeloma back down and hopefully keep it hibernating, what we call PFS, progression-free survival, for as long as possible. Because by doing that, that's how we end up actually improving your life overall and your quality of life. And the other piece is when you're penta-refractory, that's when patients have their prognosis goes down. So once you've had all these therapies in the past, so before all these clinical trials that we're going to talk about later today with BCMA therapies, CAR Ts, bispecifics, all those things, patients with penta-refractory disease didn't have very many options, really had only clinical trials available, and sometimes, didn't have any options available anymore. So we have a lot more therapies, which I'll go over in my last slide today. But again, when we see someone who's penta-refractory, we know their prognosis is poor than someone who's triple refractory versus someone who, has just relapsed. So that's sort of how we look at myeloma. Okay, so then what are the goals of treating relapsed or relapsed refractory disease? And it's pretty much the same as when we're doing upfront. Our goal is to give you the best response, hopefully the deepest response, that we can get your myeloma down as low as possible, because that usually means it stays down longer. And so we have more time to do the things we want to do. But then it's also about toxicity. So we want to make sure we decrease any toxicity we give you so your quality of life is preserved as well. So this is one of the graphs that has been used for many years at a lot of our talks when we talk to community doctors or even ourselves to say, when myeloma, because I can't cure it yet, meaning cure it and make it go away and then you never need therapy again. We have functional cures. We have people that do really well for decades at a time, but I can't say it's completely curable. The dogma was that when patients get treatment, as the myeloma gets more resistant, so each time we have to start a new treatment, we see that time that treatment works for sort of shorten, right, over time. And those penta-refractory patients, usually it used to be that patients got 6 months, maybe a year with whatever therapy we gave them next, and that was it. What's really awesome and why I get so excited about being a myeloma doctor right now and a researcher is with these new therapies, we're actually seeing it come back out again. So some of these new therapies have changed what we used to think. So this is an old picture, and hopefully we'll have a newer version in the next few months to years. But the next slide really talks about, again, as an individual patient, what are we trying to do? We want to give you that best response because that means the longer time that it's going to stay in remission or in, like I said, hibernation. And that improves survival, and then it improves quality of life because you're not having active organ issues from the myeloma itself. Next slide. Okay, so this is a little bit more complicated, and even talking to some of my community oncology partners, this is the piece that's the most important, right? Not everybody needs to get treated right away. So not everybody needs treatment right when their M protein hits that 0.5. Not everybody needs treatment, when you're MRD positive or anything like that. We don't do that in myeloma. The reason is what I just told you. We want our treatments to work for as long as possible. And if you're not having problems, we don't want to change therapy, which can maybe, let's say you're on something that's working really well, it's not giving you side effects, and your myeloma is just sort of slowly going up. If I change that, there's risk I'm going to give you toxicity, and I'm going to shorten the amount of time you're just on that therapy, and we call it refractory to that then, right? So over the long period, our goal is to say, what's the next therapy we want to give you, but what's going to be the third one, what's going to be the fourth one, what's going to be the fifth one, and in the end, we want to stretch it out as much as possible. However, we also don't want you to have, we don't want there to be toxicity. So we don't want the myeloma to cause problems. So again, it takes a little bit of savviness to know exactly when we really need to start treatment versus, hey, for this patient, we can actually wait a little bit longer. So that's why there's no black and white answer. That if someone comes to me and we see their numbers going up, one patient, I might say, oh my gosh, we need to start treatment like now, versus somebody else, I might say, oh, we have time to keep monitoring. And so really the red box there is my patients who have symptomatic, so they have clinical relapse, we should have started treatment last week, right? Those are my patients I try to get on quickly to any treatment next to get that myeloma down so we can reverse some of the clinical issues that they might be having. And then my patients in yellow are the ones that I think, okay, so they need to get treatment soon. What are my options? What can I do? What clinical trials are available? Let's get this ready and set up. And then the ones in green are my patients that I don't need to really think about it yet. We have ideas, but I don't have to act on anything yet. It's more just watching and monitoring closely and make sure we have a plan ready to go. Next slide. So then moving to clinical trials. So when are clinical trials really important to talk about? I tell my patients from the beginning. So for most patients, when you're newly diagnosed, we have some amazing therapies that just came out from clinical trials. So in the last year, more of us started using quadruplets, which was not something we did before. And this came from one of the big trials called the Griffin trial. And it showed that patients get these amazing responses, really deep responses. And then the myeloma just stays down longer and longer, which is what we want. So trials help us give better therapy. They can help us give therapy that's not as toxic. And it can help quality of life. So example of that is daratumumab. So remember back in the day when it was IV, the first time it was 8-9 hours, the second time 6 hours, and then we could get it down to 90 minutes, but it was still 90 minutes once a month. You had to get an IV put in. And they did trials looking at the sub-Q version, and they showed that people actually got less infusion reactions and less toxicity from that. And quality of life wise, I can tell you my patients, all of them that switched over, pretty much 99%, have said it's 5 minutes and I'm done and I love it. So, trials are about getting better therapies for efficacy, of course, but also to make life easier for everybody. So that actually has changed. A couple of different trials I'll mention in a second. It's actually changed how companies are looking at their drugs. They're saying, wow, patients love sub-Q. Well, if I have an IV drug, I need to change it to sub-Q now. So these things are important in the long run as well. Okay, so these are the most recent trials that became standard of care or are about to become standard of care. So these are the BCMA therapies. And I think Dr. Lee is probably going to go into this a little bit more detail. But this first one up here is a CAR T, which is the ide-cel that got approved last year. So in the past, response rates for anything that got approved by the FDA for treatment for myeloma initially had to be done in patients where there are no other options. So these patients that were penta-refractory, right? So if you got a 30% response rate, meaning a third of patients responded to it, that they got, their myeloma numbers went down according to our criteria, then it got approved by the FDA. So this was a trial last year. It was about 75% of patients got a response. So, over 2 times more than what we've ever seen before. Then we look at Carvykti or cilta-cel, that one was 97.9% of patients got a response from that. So again, things that we've never seen before. And these were all the phase 1 clinical trials that proved this to us. Then we have our bispecifics that are coming down the road. And teclistamab is a bispecific that will probably get approved this year at some point. It's already been, they've already submitted it to the FDA. And again, different than CAR Ts, but another immune therapy that the response rates are about 60, 70%, which phenomenal for patients who before, as I said, if we even got 30%, we got excited. So this is why clinical trials are so important for patients. Again, not just at the beginning or, just only when you're penta-refractory, but really now the trials that are happening are in earlier lines of therapy. So with cilta-cel, they're actually going to do a trial in Europe looking against transplant to see, can you do CAR T right after induction therapy instead of high dose melphalan and transplant. So it'll be done in Europe, so we won't have that here, but we have other trials looking at it up front, especially for our high risk patients. So this is why the trials are just so important, because this is how we get these new wonderful drugs to our patients. Next slide. Okay, so then the question of how do we improve our odds against myeloma, especially when things are so complicated. I mean, it's great to have these drugs, but how do we put them in what sequence? What do we do? And again, the main issue that, most people don't necessarily think about, but what we're always thinking about as myeloma doctors are kind of in these 3 buckets. There's other things too, so it's not complete, but patient related. So is my patient really fit and they're young and they have no comorbidities? So can I be a little bit more aggressive versus do I have someone that's in their 90s who's still doing well, but I also don't want to cause more toxicity? So we have different ways we give our therapies. So I give lower doses to my patients who have more frailty versus the full dose to my patients who don't have any frailty. And again, in the end, our goal is to make sure we give you the most aggressive therapy that will treat your myeloma, give you the best response, but not give you all the complications. Because, the sad truth is that every line of therapy, we lose patients to infections, to other, complications. So we need to minimize that as well. So that's why it becomes a little bit more complicated, but disease related. So if someone has high risk disease, or if they have a lot of disease, if they have bone disease versus, just anemia, all those things play a role into, do I need to start something that's more aggressive right now? Or is this something I can watch and then maybe treat in a little bit later? Maybe I'll have another trial that's a great trial for them that I can wait for. We sort of make those decisions with our patients. And then, of course, treatment, prior treatment. So what types of treatments actually did you have a good response to? So if I have a patient that did really well with a PI, a proteasome inhibitor, I'm probably going to bring that back when their disease is getting a little bit more aggressive. Not the same drug maybe, but in the same category of drugs. Versus if I had a patient that really did well with an IMiD, then that's what I'm going to bring back as the next line of therapy, or early in their therapy, to make sure that they get the best response. In the end, I'm hoping one day we'll have biomarkers that tell us that each patient, I could do a blood test and I know which treatments are going to work the best for each of you. But right now we don't have that. And I think we're still far away from that. So that's why we use our clinical judgment to say, okay, this myeloma with this was what's going on in the background for my patient, along with some of the socioeconomic issues, what is the best therapy to do next? Okay, so this is the NCCN guidelines. So I do a lot of talks with our community oncologists. I just did one on Thursday, and we need their help to be able to treat everybody. Not everybody can go to a tertiary center to get their myeloma treated, right? And we know that. And so it really has to be a partnership though. And that's going to be in the best interest of our patients. We have patients that don't live in Houston. Or near any of the centers, and they need to be able to go to work and they need to be able to do things they want to do and not drive for 4 hours just for treatment. So really that's where this partnership with community oncologists happens. Now, community oncologists get a lot of the information at some of the big meetings that we present at, but they don't necessarily see that many patients. So it's hard for them to know how to apply all the new treatments and everything we have to their patients. What order do I put it in? And I'll tell you, a lot of times people end up doing algorithms. They kind of treat everybody similarly because it worked for this patient, a couple months ago. I'm going to do the same thing again because that's what I know. And so what they have as a reference is this thing called the NCCN Guidelines. So Dr. Weber's listed on there, and Dr. Lee actually, who's speaking next, was a part of the update recently. And so these are physicians that are myeloma specific around the entire country and even international sometimes, that really make sure that all the new trials and all the new therapies are looked at and vetted and then put into this category. It helps get insurance approval sometimes, to be honest, and it gives the oncologists kind of an idea of where they should go next. But if you hit next, that part will disappear. These are all the treatments that are listed for patients who are relapsed or refractory. So this first group is all the treatments for patients in the first 2 to 4 lines of therapy. So in the relapses that they've had early on. And at the bottom over there is sort of what's approved so far by the FDA for patients who are relapsed after 4 lines of therapy. One, they don't have access to all these drugs, so we have to work with them to make sure we get patients to the right therapies when they're supposed to. But there is no direction on what treatment to use, when to use, how do I sequence them, and that's really where we can help make sure that they're not giving something like bendamustine or Cytoxan right before we're going to try to give an immune therapy, because that can actually affect your response to immune therapies. If they kill off all the immune cells, then these other therapies won't work as well. So there's a lot of, I think, back and forth with our community doctors that we really need to do. And again, we have these great options, but if you don't practice it as much, it's going to be a lot harder to know how to apply it. So next slide. Perfect. So then basically this was my last real message, that having a myeloma specialist just as part of your team, doesn't have to be the person treating you, but just having them back, especially when you have to make decisions of, do I need to start treatment? Do I need to change treatment? Or is this toxicity okay? Or is it going to cause problems long-term? Really, that's where I help my patients out at those decision points, that we can, make a decision together to make sure you have the best outcomes. And with that, I think that's my last slide. Perfect. So thank you to all our patients and caregivers.